talking about, where did we stop? Did we stop at community rating and experience rating?
Yep.
Right. So, we said those are the ways of setting the premium in the market, right, the community rating and the experience rating methods. Will someone remind me what was experience rating? What is experience rating? One person. Someone.
I just wrote down this based on past experiences.
Okay. So, it is based on the past experiences of the people that are included in the group or included in the pool, right, and some of those past experiences could be based on what? Correct, right. And how about community rating? It's a broader category where the entire, but the basic idea is that in experience rating within the large pool, within the same group, some people may be paying more and some people may be paying less, because the insurance companies, based on the past experiences of some of those people, may deem some people as more risky than the others, right. Whereas, in case of community rating, once you have created the group, once you have created the large group, that large group usually pays the same money or has the same premium, okay, and the group itself may be created based on certain very loose categorizations like gender or age or something like that, but once those categorizations have been done, then the entire pool pays the same amount. However, that may sometimes be inefficient, as you can understand, because within that group of, let us say, females, you may have some high risk females and you may have some low risk females, right. So, the community rating does not take that into account. Is that clear? Now, next we move on to two most important characteristics of the health insurance market. Okay. These two characteristics, the first one is called moral hazard. And the second one is called adverse selection. So, the first one is moral hazard and the second one is adverse selection. Now, due to these two characteristics in the health insurance market, you have certain inefficiencies in the market. It often leads to a situation where it is very difficult to set the price in the market, and you know the price in the health insurance market is basically the premium that we are talking about. So, it becomes difficult for the market to work and the price to be set in that market due to the presence of these two characteristics. Now, these characteristics are not specific to the health insurance market, these are there in any insurance market, but in the health insurance market this becomes even more critical. So, in auto insurance you have the same problem, in life insurance you have the same problem, but in health insurance these problems manifest themselves in a more critical form. Okay. Now, what is this moral hazard? Moral hazard basically refers to a change in behavior of an individual, change in the behavior of a consumer when he has health insurance coverage. Okay. Please write that down. It is the change in the behavior of a consumer or an individual because he has coverage, some form of health insurance coverage. Okay. Now, we are not going into the complexities of what is the nature of the coverage. Is it full coverage, is it less coverage, or is it a coverage, is he under an insurance plan that is more holistic, which provides for preventive care and it provides for more a wider range of services. We are not going into those categorizations. But moral hazard just means that a person who has insurance tends to behave differently than a person who does not have insurance, as simple as that. Okay. Now, what would that difference in behavior be, do you think? A person with insurance?
More risk-taking, possibly?
What do you mean by more risky?
You're just not going to take care of yourself as well because you know you have health insurance to patch you back up if something happens.
Correct, that is one thing, definitely. So, a person with insurance will tend to be more of risk loving, right, But please remember, the fact that he bought health insurance was because he is a risk averse person, right? That is what we said last time, that it is the risk aversion nature of individuals that kind of triggers them to buy health insurance. But once he has health insurance, then it may be so that the person might become a little careless and may become a little, kind of casual or risk loving in some sense and may not be taking care of himself. What else? Steve, did you have a point to make? So basically risky behavior, like he might be willing to do things which are more adventurous or risky. What else? If I have insurance, what do you think I'm going to do? Go to the doctor more frequently. That means there will be some wasteful usage of health care, right? If I do not have insurance, then I will think several times before I land at a doctor's office, because I know whatever money has to be paid will go out entirely from my own pocket. But if I have insurance, then I am not going to be so cautious, and I will use health care more often, and I will use more health care in more quantity. Do you agree? So then we can say that moral hazard will lead to two obvious things: risk taking and higher usage of health care than what is required. Now both these things are going to lead to some inefficiencies in the market. It's going to lead to something, it is going to lead to a situation where there is a disagreement or where there is a mismatch between what the insurance company is thinking and what the consumer is thinking, right? The insurance company has sold you insurance at a certain price, thinking that, okay, you will go to the doctor when you fall sick, and hence they have set the expected payout for you, and they have looked at your history and asked you to fill in a questionnaire. But they do not know that once you buy insurance, you will be a changed person. You will start taking more risk, and you will start going to the doctor even when it is not necessary. For a small nick in your finger, you will run to the doctor. They have not taken those things into account. So the price that has been set while the insurance policy was being sold to you is not tracking this change in your behavior. Do you see what I am saying? So there is a possibility that there will be some disagreement or some kind of, what should I say, the insurance company and the consumer will not be able to meet at a point as far as their behavior and expectations are concerned, right? That is exactly what we mean by inefficiency. Okay. Now there must be some ways of kind of solving this problem then, or at least reducing this problem. There is no single way of entirely solving the problem of moral hazard in any insurance market. Moral hazard cannot be reduced to zero in any insurance market. And similarly for the health insurance market, the problem of moral hazard cannot be cured altogether. You can only have measures that reduces the problem of moral hazard. Can you think of one such measure? We have discussed those measures in class. Very good. So one way to treat moral hazard or address moral hazard will be to have those stipulations within the insurance policy, to have different stipulations in the insurance policy which makes a person a little bit more sensitive towards the price, right? And what could those be? The first, of course, co-insurance, co-pay, deductibles. And I will not go into the details of that because we have covered those in sufficient detail, but the idea is that any of these arrangements within the insurance policy will make the consumer or make the individual a little more sensitive towards the pricing, or will make the person a little more elastic in his demand for health care, correct? Or in other words, it will create a difference between the effective and the nominal demand curve of the consumer, if you remember when we covered this, right? So that way, this behavior of a consumer to use more of health care and take more of risk, that could be somewhat curbed if the insurance policy had one of those stipulations rather than 100% coverage, correct? Yes, because you know 100% coverage is perfectly inelastic, that vertical demand curve. So, we are just saying it is going to be a flatter demand curve for healthcare. Secondly, the second provision that could be there, which can solve little bit, not really solve, but kind of address the problem of moral hazard, is customary payment. Okay. And this is something that you see in a special kind of insurance arrangement which is called fee for service, FFS, fee for service. It is a customary arrangement in fee for service plans. What do I mean by fee for service plans? Fee for service plans are when you go to a doctor, you visit a doctor, and whatever is the money that you pay to the doctor, that just gets reimbursed by the insurance company. Okay, so it is an arrangement between you and the insurance company where you pay the premium, and by the virtue of paying that premium, you are entitled to the services of a doctor, whichever doctor you choose to go, and the insurance company does not care. You pay to the doctor, and whatever you pay to the doctor gets reimbursed to you directly by the insurance company. That is fee for service. Okay. And sometimes it could be alternate also, where you know the insurance company negotiates with the doctor itself, and you go to the doctor, and you know there is a negotiated price, and the fees gets reimbursed to the doctor itself. Okay. So, whatever services the doctor provides to you, the insurance company will pay the doctor. But you can understand that here there is a very high possibility of this moral hazard problem, and especially this over usage of healthcare. Because on one hand, you can go to the doctor as many times as you want, even when you do not need the services of the doctor, and also the doctor can induce a higher demand for healthcare, because remember the demand for healthcare is induced. So, the doctor himself can induce a higher demand for healthcare, because he also has his blended interest of kind of getting more out from the insurance company. So, there will be moral hazard, higher moral hazard because of that arrangement. So, to stop that, usually in such fee for service plans, the insurance companies set a certain price tag for different services provided by the healthcare providers. So, it will say, okay, if you have this kind of a dental surgery, like let's say you have a wisdom tooth extraction, this is going to be the price no matter which doctor you go to. This is how much you will get. If you have gallstones removed by a laparoscopic surgery, this is the price. Okay, this is what I am going to pay out. No matter which surgeon you go to and how you get it done, I do not care. This is the price. So, basically setting a stipulated price or setting a price tag by the insurance company for a range of services. Okay. In that case, what happens? In that case, if you go and get that service done, no matter what happens and which doctor you have gone to, you just get that tagged price, that listed price, and anything more that you have spent has to be spent out of your own pocket. So, you just get the customary fees or the customary payment. Any issues? Huh?
Some echoing in here?
Today?
You might want to ask them, because they can hear
Okay.
whatever is going on. Okay. So, where was I? Okay. So, if anything more than the customary fees or anything more than that listed price is paid, that needs to be paid by the consumer or the patient. So, once again you can understand that will kind of stop him from overusage or wasteful use of health services. He will try to kind of limit his use, because he knows that if I end up going to a doctor who is going to take more money from me, I am not going to get all that money reimbursed. I will only get the tagged price that the insurance company has set. So, I might end up spending more out of my pocket, right? The third way of stopping moral hazard or addressing the issue of moral hazard is managed care. the third way is when the insurance company sets up managed care. Okay. Now, this managed care or managed care organization, we will come to that in a little bit, but managed care arrangement is different from this fee for service arrangement. Okay. There is a clear distinction between fee for service and managed care. Okay. Fee for service is just, you choose your own doctor and you just get reimbursed, and there may be customary fees for fee for service and all of that, but the idea is that the insurance company does not have a say in which doctor you go to. The insurance company may have a say in what is the price that they are going to pay, or what is the money that they are going to reimburse for whatever service you get. That is, they may have a say on the customary fees, but they do not have a say on which doctor you go to. Okay. But in case of managed care, it is just the opposite in that sense, that the insurance company has a direct say and a direct opinion about which doctors you have to go to. Okay. So, they create their own list of doctors and tell you that you have to go to those doctors. Okay. And the insurance company does its own negotiation with the doctor, whatever rate. Okay. So, there is a direct incentive for the insurance company to send you to those particular doctors, because they are negotiating the price with the doctors. And in certain cases, in certain forms of managed care can be of different forms, and we will look into those forms or the different kinds of managed care. And some kinds of managed care, you not only have a list of doctors, but you have some primary care doctors who are called the gatekeepers, gatekeeper physicians. These are some primary care doctors to whom you have to go to before you can visit a specialist doctor. Okay. So, these gatekeeper physicians or these primary care doctors are going to evaluate your need, and based on your need, they are going to send you to a specialist, refer you to a specialist. So, you can understand this is somewhat like a filtering or sieving of patients. So, what is the insurance company doing? It is actually trying to filter out some people for whom this moral hazard is super high. Those people will get sieved out. Some people who are running to doctors just because they have insurance, those people will get stopped by the gatekeeper itself, and they will not be able to reach the specialist. Okay? And in some cases, in a managed care form of insurance, there will be need for pre-certification or pre-approval. That means you need treatment, the gatekeeper physician tells you that okay, you need so and so knee surgery, and the expense of this surgery is going to be $3,000. That is not enough. Now you need to fill out a form and you need to get it pre-approved by the insurance company. The insurance company has to say, okay, fine, yeah, I'm going to pay for this surgery, and then you can go to a specialist, and then you can set up your surgery or whatever. Okay, managed care. In Missouri state, the insurance that we have through MedPay, it's of this kind. Okay, we are expected, we do not have a gate care physician per se. We are encouraged to go to Taylor Health first, right? So, they are kind of our gatekeepers who try to evaluate that how big is the need, but we could go to specialists also at Mercy Hospital. So, we do not have gatekeepers. Problem? Okay. So, we do not have gatekeepers as such, but we do need pre-certification and pre-approval in case of lot of services. We just cannot go to the specialist and say, okay, I need this surgery or I need this injection, please just give me this injection. The physician will tell me that I need to get it pre-certified or pre-approved through your insurance. Okay. And that happens a lot of time. And from my personal experience, when I went to the Mercy doctors, my OBGYN at Mercy, they were running initially in the first 3 or 4 months, they were running some tests they wanted to do for, finding what is the probability of birth defects and so for the fetus. They first told me, would you want to have that? I said, yeah, definitely, I would like to take advantage of that. They said, we don't know if your insurance is going to approve that. So, if your insurance does not approve, then it is going to be $3,000, and if your insurance approves it, then it is going to come down to some $350 or $400. So, immediately I said that okay, first find out whether my insurance company will approve or not, and that happens to all of us, correct? Okay. Now, the fourth one that you have, that's called the stop loss provision. Okay. The stop loss provision is similar to deductibles. Okay. It is a form of deductible, but there is an implicit difference between deductible and stop loss. Now, deductibles, if you remember, we said that deductibles were kind of setting different levels, right. So, you have to pay up to this much amount, after that you get 20%, you have to pay 20% and 80% will get reimbursed. Then you reach another slab, after which 40% you have to pay maybe 10% and 90% gets reimbursed. Then you reach another slab, 5% will be paid and 5% you have to pay and 95% will get reimbursed, and eventually after meeting a certain amount, your entire thing will become free. You will be entirely covered, 100% will be paid by the insurance company. So, most deductible plans work in that way. They have multiple thresholds or they have multiple levels. After each level, the amount of responsibility or the percentage of the responsibility of the patient reduces, correct? In that sense, the stop loss provision is exactly the same, but here you just have one single threshold. Just one single threshold. So, you can think about the stop loss provision as a deductible plan with only one threshold, with only one level. That means you meet this level, whatever, $1,000 or $2,000, and after that you have 100% coverage. There is no 20%, 30%, 40% thing. So, you meet $800 or you meet $1,000, and after that you have 100% coverage. Okay. Usually in the stop loss provision, that threshold is called the stop loss threshold, and usually that stop loss threshold tends to be very high. Okay. So, it is usually something as high as, let us say, $2,000 or something like that. Now, what do you expect to see in this kind of provision? Do you think this is very efficient? If your answer is yes, why? If your answer is no, why? How successful do you think a provision like this would be in dealing with this problem of moral hazard? That is my question. Yes, Tyson?
I think it's going to be dependent on the amount of the threshold. So if you have a very high threshold, you're going to think about having something done unless it's really going to hit that and then some.
Okay.
If it's a real low threshold, you're probably going to be more apt to use the plan because you're going to easily hit it and then everything else is free.
That means anywhere below the threshold, your moral hazard problem may be addressed, but once you have met the threshold, then your moral hazard comes back in full force, because it is 100% coverage after the threshold, correct? So, that means it can deal with moral hazard when your healthcare costs are low. If you are having some kind of healthcare expenditure which is low and hence you are staying within the threshold, then that entire expenditure is going out of your pocket and your insurance is not kicking in. So, you are extremely sensitive to that healthcare cost and that price. So, moral hazard is addressed there. But once you have reached that threshold, that means you have a high expenditure on healthcare, you will meet that threshold easily, right? After that you have 100% coverage. So, then that moral hazard problem comes back in full force, then it is not getting cured. So, it is not a very efficient system.
This is simply max out of pocket yearly?
Correct.
Okay.
Essentially that. Okay. So, if you have less expenditure out of pocket, as long as you are having less expenditure, as long as you are having a healthcare procedure or treatment that accounts for low expenditure, moral hazard will be treated by this. But as soon as you have a healthcare expenditure that is exorbitantly high, then you will meet this threshold easily. And once you have made that threshold, the entire risk is transferred onto the insurance company. So, you are not liable anymore, and moral hazard will be back in full force in your behavior as far as healthcare usage is concerned. Is that clear? Okay. So, that is why in each and every method, in all those 4 methods that we have discussed about mitigating or kind of addressing the issue of moral hazard, they can only contain moral hazard, they can restrict moral hazard to a certain extent, but none of these methods promise to remove moral hazard altogether. It is not possible to remove moral hazard in the health insurance market. Is that clear? Okay. Now, moving on to the next one, which is adverse selection. What is the class schedule like on Monday for you guys?
We're not here until 4 o'clock.
Oh. I wanted to do one extra class. Okay. As far as adverse selection is concerned, adverse selection just means that for some individuals, when a group or a large pool is created by an insurance company, for certain individuals they may have different characteristics than an average person in the group. So, what I am trying to say is kind of trying to take you back to that definition of expected payout. If you remember, what was expected payout, that capital E that we defined last time? It was the money that the insurance company would pay out for an average person in the pool, right, based on the payments made for an average person in the pool, correct? Now, we are saying that within that pool, when the insurance company creates a pool, there may be some individuals whose health characteristics and personal characteristics are very different from an average individual, right? Then you cannot subject that individual to that same expected payout that you have set for the average person. Or in other words, whatever way you are setting that expected payout, that is becoming faulty for this person who is an aberration from the average, right. So, there is a possibility of inefficiency in the market if you have more such people who differ from the average within the group, right, correct. And also please note that these people who differ from the average, these people who deviate from the average, their purchasing behavior of insurance may be very different from the average person and the less than average person, correct. So, adverse selection basically refers to difference in purchasing behavior, and by purchasing behavior I am specifically referring to the purchase of health insurance, in purchasing behavior due to difference in characteristics, and by characteristics I mean personal as well as health characteristics of individuals from average. Okay. Now, do all of you understand why that is, why I am referring to that as a problem? Did all of you understand that part? That why is this a problem? Why should it lead to inefficiency? Do you have any question there? Is that okay? Who wants to? Huh? They are the outliers, correct, yes, they are basically the outliers. But why are having outliers a problem? Did you understand that part? Because I have set my capital E, I have set my expected payout based on the average guy, right. So, if I have more outliers in my pool, then that price that I have set is a faulty price. It should have been something else, because I have more of these individuals who are outliers, okay. So, that is why we are calling that an inefficiency, or we are calling that a problem for the health insurance market. Okay. Similarly, just like moral hazard, there is no one way that absolutely treats the problem of adverse selection. Adverse selection always stays in the health insurance market, it can never be driven to a zero. Okay. However, there may be some ways of trying to kind of address this problem. The first one is a simple method which the insurance companies may follow. That is, the insurance companies, when they are trying to create the group, when they are trying to create buyer groups, they will try to market, they will try to do advertising, promotion and marketing to low risk or more average individuals, and this average is according to the insurance company who they consider to be average. Okay, so we cannot say what is an average, right? We cannot really have a definition for average, but usually the insurance company will have its definition of average on its books, and it will try to market its policy to people who are low risk or such average individuals by going to communities Okay. So, what I am trying to say is that in certain, let us say an insurance company thinks that the average person for them is a younger person, and this younger person will have less usage and less diseases and less pre-existing conditions. So, that insurance company might start marketing student health insurance. Okay, go to universities and colleges and market student health insurance, and in that way get more subscribers from the group who they consider as average. Okay. So, what is happening? Once the group is created, you have less aberrations from the average. Okay. So, that is just a marketing strategy that may be taken by the insurance company. The second method by which the insurance company may try to deal with the problem of adverse selection is direct pay. The direct pay method. Okay. It is once again that okay, you pay a premium and you have health insurance, okay, but you have to, whatever gets reimbursed to you or whatever money you receive, that is directly paid to you. So, this is something like customary fees in case of moral hazard. Okay. So, if you are an aberration, then you have to pay some money directly to the insurance company, which is different, which is going to be different from the average person. So, basically what is it trying to do? It is trying to do experience rating. This is the same as experience rating. That means all people who are outliers will have to pay a higher payment, a higher money to the insurance company than people who are kind of at the average or less than the average. Okay. So, this is in some way you can think of this as experience rating, paying through experience rating. That means people who are aberrations, who will behave as aberrations, those people will end up paying a higher price for the insurance than the people who are at the average and do not use as much health care. Okay. Is that clear? The third one is group rating, or sorry, the third one is community rating within the group. Community rating. Now, before we go on to how and why community rating will solve the problem of adverse selection, please understand that at the end of the day, these insurance companies are all business firms, right? So, their only objective is profit maximization, if you remember. So, they are trying to earn the best possible profit. So, if they end up creating a group where there is adverse selection problem, that means if they end up creating a group where there are more outliers or aberrations from the average, then this expected payout that the insurance company has set, that is a faulty price of the insurance, right? Price should have been higher because there are more outliers. So, that means that is hampering, adverse selection hampers the profit motive of the insurance company. Do you agree? So, if that continues over time, what will the insurance company do? They will adjust that expected payout, they will bump it up over time, because now they know that this group, I have created a faulty group of people where I have more people who are on the higher side of risk, and next year when I set my average payout, when I try to calculate my capital E, that capital E is going to be higher? Do you see what I am trying to say? Once in the first period, I may not realize as the company, I may go wrong. But in the next year, once I have seen these people for 1 year, I will know that I have gone wrong in setting my expected payout. So, I will adjust my expected payout, and that adjustment will raise the expected payout next year. Or in other words, over time, the insurance company will raise its premium for the group, correct? And if it raises its premium for that entire group, there is a possibility that some of those individuals who really do not need the insurance, or some of those individuals who are in better health, they decline coverage, they give up on health insurance, and the pool only consists of individuals who are high risk or the unhealthy people who absolutely need insurance, right? Do you agree? That will drive the premiums up even more for those unhealthy people. But that high premium is kind of a disincentive for the healthy people, because you will think that, okay, I am not claiming insurance year after year, so why should I keep paying this high premium? Let me just drop coverage, because anyways I don't fall sick as much. When I do, I will pay out of my pocket, right? So there is a possibility that the people in better health just go out of the group, and the group is just left with just the more risk or the more unhealthy people. Okay. So now this community rating, as you know, this community rating is kind of catering to everybody and charging the same price to everybody, right? So the insurance company may think that, okay, let me try to create a very large pool. If I try to create a very large pool, then while I have some outliers, I will also have some people who are, I will have more people who are at the average. So, okay, let me discount for the fact that there will be some outliers and there may be many outliers, but at the same time, there will also be many people at the average. And if I charge a price which is not super low, not super high, but somewhere in between, the moderate price, okay, but I charge that same price from everyone, then there will be a low probability of losing anybody from that group. So the first thing is create a larger group of individuals, okay, not a narrow small group. And when you create a large group of individuals, while there is a possibility of having people who differ from the average, that is, while there is possibility of having adverse selection, there is also a possibility of having more people around that average. And then if I think that, okay, fine, I am going to charge the same price from everybody, the average which is based on the average, that is the expected payout, then that average price obviously will not be super high or super low, right, because I have all kinds of people, so the average will be somewhere in between. And if the average is somewhere in between, then the expected payout is somewhere in between, and if the expected payout is somewhere in between, then there is a lower probability of losing these people on account of spiraling premium. Okay. Now, this is in theory. In theory, we are saying this, but in practice, will this work or not? Like Tyson mentioned last time, that why don't we create a nationwide pool? Exactly that same thing. Why don't we create that large pool? That is exactly what this is saying, that this will solve the problem, or this will at least address the problem of the adverse selection. The problem is when they tried to do something like this, for example, in 1993 in New York, they tried to do this on an experimental basis, where the state government of New York, they stipulated that all private insurance companies, they have to set premiums by community rating. There will be a single premium for the groups that they have created. They all have to follow community rating. Okay? So this was a policy in New York in 1993, and they compared the results of the policy for New York with two other states, that is Connecticut and Pennsylvania, PA, right? Pennsylvania is, okay. So, they tried to compare it with Connecticut and Pennsylvania, where they did not have community rating. So, these two people did not have community rating, and by law in New York, they enforced community rating for all insurance companies. They found that compared to these states, there was no increase in coverage in New York. It did not help. There was no improvement. By increase in coverage, I mean how many people have insurance. So, it should have improved that number, right, because we are saying that if we do this, then it is going to stop people from declining insurance. So, post policy, the number of people who have insurance should have gone up, but that did not happen. Okay. So, that means that in the real world, individuals do not think that way. In theory, that may be true, but individuals as consumers, we do not think in that way. In practice, this does not work towards solving the problem of adverse selection. So, that means while this might work in theory, while the textbook might tell you that okay, this might be a way to address the issue of adverse selection, in practice it does not really work. Okay. So, that means due to adverse selection, there may be a problem of once again inefficiency in the insurance market. Okay. Now, there is a paper, and I cannot force you to read that paper, it is an econ paper, but you might want to look up at the results. I do not encourage you to read the paper because it will be super mathematical. Rothschild and Stiglitz, okay, 1976 or something, I do not remember the year. There is a paper where they try to kind of evaluate this problem of adverse selection, and they say, okay, so if there is adverse selection, will the market fail? Will the insurance market fail? Okay. So, what we are trying to say is that okay, since you have this insurance market, if you just rely on the insurance market, will there be failure of the insurance market to reach an equilibrium, and will government intervention become necessary in that kind of market? Okay, that is what they are trying to answer. So, they say according to them, according to these guys, it says that no, it is not necessary, because please understand why is adverse selection happening in the first place? Adverse selection is happening in the first place because there is not perfect or symmetry of information between the insurance company and the patient, the consumers. The consumers are able to hide their personal characteristics and their health characteristics from the insurance company, right. If the insurance company knew everything about you, then they would be able to do perfect assessment, and they would be able to set the perfect expected payout price, correct. The fact that there is asymmetry of information, that is why in the first place you have adverse selection, correct. So, this paper is basically saying that it is not necessary that to solve the problem of adverse selection, you have to have perfect information between the insurance company and the individual. It is not necessary that you have to have symmetry, because that is not possible. Individuals will hide from the insurance company. That will be true for any insurance market. But as long as the insurance company is able to gauge something about you from your purchasing behavior, then this problem can be solved to a great extent, and government intervention in the insurance market may not be necessary. Okay. Now, the next part of the chapter is what are the kind of insurances that you have in USA, or what are the provision, in what way is insurance usually provided or accessed by the people of USA. First, the most common one, which has been very popular since 1950s, is the employer provided insurance. You work for a company, the company provides you insurance, because in the labor market, when you try to go look for a job, it is very difficult for people in USA to bid for a high wage, and there is not much raise in wages over years, because USA does not really have a very well developed system of collective bargaining or labor unions. Right? It is a capitalist market, so you do not have a very strong hold of labor unions. So, wages, okay, compensation in terms of wages does not increase much. So, another way of compensating the individuals or the workers is to provide them non-wage benefits or fringe benefits, and providing health insurance is one of those non-wage benefits. So, this non-wage benefit or provisioning of health insurance through the employers has been very popular in USA for quite some time. Okay? And the other alternative could be just private health insurance, where you buy your own health insurance. So, let us think about the employer based health insurance. Okay. When you have employer health insurance, obviously you have certain advantages. Okay. What are the advantages? The first advantage is that you can somehow, the insurance company can somehow address the problem of adverse selection. Why do you think that will happen? Why in case of an employer based insurance, let us say I am the employer, I have a company A and I want some insurance company to provide insurance to all my employees.
They can make policies to work there, you can't smoke, they can reduce risk factors.
Who can make policies?
The employer.
And then how does that help the insurance company?
It keeps a better, your averages are more healthy, I guess, or lower risk.
Very good. So, that means when you are creating a group within the same employer. So, this is as if this was creating that large pool, the insurance company is creating a large pool, but that pool only consists of employees of this company A, right. And like George said, that the employer may stipulate certain restrictions on its employees, like no tobacco, and there are certain companies have these wellness plans, you must exercise 3 times a week, then you will get these reward points. Or we have today is a yoga day, and everybody must bring a yoga mat and practice yoga. In the corporates you do have things like that. So, that means the employers themselves are trying to regulate your behavior, and by certain regulations they may be able to kind of stop aberrations within that group, right. They may be able to bring more people towards the average. Or the employers may have certain hiring policies, like not hiring people who are above 25 years of age, although it is illegal in USA to do discrimination of that sort, but implicitly we know that that happens. In certain industries they do not hire women, they want more men. Certain industries they do not want men, they want more women. So, those kind of implicit discriminations happen all the time in the corporate world, although it may be illegal to discriminate on those grounds. But what we are trying to say is that through the policies of the employer, the insurance company may be able to track the risk properties and create a more uniform group or uniform pool of individuals, right. So, the advantage is a more homogeneous group or pool, whatever you want to call it, homogeneous in terms of their risk properties. Okay. And if that is the case, then you can understand that the insurance company has some ways of tackling adverse selection in such homogeneous groups, maybe by doing something like a community rating. It is easy to implement in that kind of a homogeneous group, that everybody pays the same price for the insurance, or everybody is offered the same kind of insurance, and the employer and the insurance company negotiates with the employer that, okay, great, you have these employees, now pay the same price for all employees. That is exactly what we have at MSU. We are supposed to pay for a single person, we are supposed to pay for one person, it is $30 a month, the premium. Okay. And if I am a non-smoker, if I am not a drinker, okay, and if I do all my vital statistics every year and they are all normal, which means I do not have diabetes and I do not have cholesterol and I do not have all of those other things, thyroid and this and that, I have to fill in a questionnaire, I have to go to Taylor Health Center, they will do all my vital stats, do all the blood tests, then that $30 will be waived. That means I get health insurance at $0 per month. And all faculty who come under, who meet those restrictions that has been set by MSU of being, non-smoker, non-drinker, at least exercising 2 times a week with normal vital stats and normal blood report, they all get insurance at that same price, which is $0. That means the $30 is being paid by MSU to that insurance company. Okay? So, basically we are all being charged $30 per month. Because we are homogeneous, and how has that homogeneity been created? That homogeneity has been created by the restrictions imposed by our employer, MSU. Okay? So, that means this is some kind of a community rating that is going on there for these group of people. Okay? So, that is one big advantage of employer based health insurance, that there may be ways to address the problem of, adverse selection within that group, within the group of employees. Okay? But there are also disadvantages. Obviously, there is always merit and demerit of everything. The first disadvantage, what can you think of? What is the first disadvantage, would you think, of employer provided insurance? If you lose your employment, you lose your insurance. So, your insurance is tied to your job. It is coming with the job, it is a fringe benefit. No job, no insurance. That is the first disadvantage. Now, there are policies, the federal government has tried to kind of stop this, because this is a very crucial situation in USA where you have hire and fire rule. Anybody can get a pink slip any time in this country. So, in this country that will be a major problem if the government does not step in there. So, government has policies. In 1985 there was a policy that was brought in, you may have heard about this. Have you heard about this? COBRA, the Consolidated Omnibus Reconciliation Act, but what is the B? I forget. Anybody Let me see if I have it in my notes. I should have it in my notes somewhere. Budget. The Consolidated Omnibus Budget Reconciliation Act. Okay. So, what did this act say? What did this policy say? This policy said that once a person loses his employment, his employer still has to provide him insurance for the next 18 months. Okay, the same insurance has to be provided. So, if you fire somebody, you still have to provide the same insurance to the fired employee for the next 18 months. So, that is kind of a way, it comes with the severance package, you may think about that in that way. Okay. So, what we are trying to say that although there are these policies which kind of stop, which is said that okay, this will solve this problem, but they are not actual solutions. They are just on papers, those policies. In reality, it is not helping the individuals. Okay. And the second problem that is there is also called job lock. What is job lock? Job lock basically means restricted mobility of the workers from one job to another. That means changing of jobs becomes difficult. You are locked in the same job. Why do you think that happens? Because you have set a track record. If you are a person at the job while you are working for one company, that is company A, let's say you have had a lot of medical issues and you have had a lot of claims that have been filed for your health. So, you have been identified or red flagged as a person having comparatively worse health status, and you have been identified as a person who has made a lot of claims on the insurance. Then, although your employer is not supposed to discriminate with you, yet there is implicit discrimination against you because you are claiming more fringe benefits than average. Okay. So, it is difficult for you to get recommendations and references from your present company when you want to change a job. because you have somehow created a disrepute for yourself as being not as healthy as others and making more claims in insurance. So, somewhere there is a red flag. Now, there is also policy on paper to stop that, which is called the Health Insurance Portability and Accountability Act. Health Insurance Portability and Accountability Act, which just says that you cannot discriminate a person based on his health history and health issues and his history of insurance claims. That means that is confidential information. You cannot delve deep into that, and you cannot dig out that, and you cannot discriminate against that person. But once again, that is in theory. In the real world, it becomes very difficult for a person, once he has bad health status, it is difficult for such a person to move from one job to another. It is difficult for him to find another employment when he loses his first employment. Okay? So, those are the disadvantages of having employer provided health insurance.